It's a great pleasure to be here, and I'm going to try and pick up on some of the themes that Senator Kaine mentioned under this idea, perhaps this hypothetical question today: can technology really help solve America's healthcare problem? When I think of other industries in which I've not participated, I think of technology as really being the transformational force that has driven value and improvement in the delivery of products to human beings that have really allowed the American economy to thrive. But healthcare has clearly lagged in this regard. Healthcare is one of the few fields that actually seemingly defies Moore's law, right? That there's a doubling of the technology that occurs every year, and that adds this value. So what is it about healthcare that has belied the ability to embrace technology, and how do we see the opportunity to use technology as a way to really drive the reform that Dr. Kaine talked about? Jackie already mentioned my disclosures. This is a sort of strange thing you have to do when you're in academia, right? The idea that, God forbid, I have a partnership with someone that I didn't tell my president about. But here are the sorts of things I'm going to begin discussing as a context for understanding the role of technology. And first, I'm going to begin a strange segue from Senator Kaine by arguing that actually healthcare reform is not of a political origin. The driving forces behind healthcare reform in America are biological and demographic. The biology is simple. 50 to 25 years ago, Americans died of infectious diseases. People got rheumatic fever or scarlet fever, or shortly before that, polio, and they succumbed quickly to what was a fairly finite group of diseases, infectious diseases. But as we became very good at treating infectious diseases, the world of chronic disease has emerged, in which human beings are living longer and longer with chronic conditions, and as Senator Kaine said, which we now are able to successfully treat. But that burden of chronic illness and the chronicity with which people suffer from those illnesses creates an additional financial burden to the healthcare system that didn't exist 25 or 50 years ago. And I'm going to spend a little time talking about demographics. But I'd like you for a moment to dispel any belief you have that this is political. It's not. There are really compelling biological and demographic forces that are driving reform. The second is that population health, which has become a buzzword in the era of reform, is unfortunately, I believe, a euphemism for simply moving risk from payers to providers and patients. And what one is seeing in the restructuring of payment reform is our insurance companies that no longer want to accept the risk of caring for a population of patients and are basically passing that risk to providers, and insurance companies and employers who, seeing the rising costs of healthcare, are passing those costs on to employees in the forms of these growing number of high deductible health plans. So at the end of the day, while the theoretical notion that population health is about serving the health and well-being of the population, I think unfortunately a political force has created this notion that's largely about payment reform. The third thing I'm going to suggest to you is, as those of you who bring enormous technological experience here, is don't focus on payment reform. Focus on practice reform. Clinical delivery system reform is where the opportunity for technology rests. And this is this idea that you can drive value in healthcare if you really focus on process excellence. And technology has driven process excellence in almost every other industry. And that's why I believe technology and innovation can really be the key to driving process excellence in healthcare. So the goal, I think, in embracing technology in health and medical care is this concept of providing what a patient needs when they need it, on time, the first time, no defect, no error, no waste. That, to me, is the essential goal of any significant effort at healthcare reform. And where the savings come in that story are the on time, the first time, no defect, no error, no waste. That's where one can recoup as much as $1 trillion of the $3 trillion that is spent on healthcare. And I'll go through some examples of that. So the demographic force that is the driving force behind healthcare reform begins with this iconic image in 1965, just 50 years ago, with President Johnson signing the Medicare Trust Fund Act, one of clearly, unquestionably, the greatest social programs, perhaps second only to Social Security, in the nation's history. And this picture is iconic in that sitting to President Johnson's left is President Truman and his wife, Bess. And President Truman and Bess Truman were the first recipients of a Medicare Trust Fund card that day. And that in and of itself is meaningful because in 1948, President Truman was the first administration to actually propose healthcare reform when President Truman suggested there should be a single-payer system in America. 1948. Post-World War II, returning veterans unable to access care, an evolving VA system at that time, but a fundamental debate in 1948 about how the country would fund healthcare. And there was a great proposal that had bipartisan support that President Truman put forward for a single-payer system where all Americans would have access to healthcare. And it was defeated by a single lobbying group. Anybody know who? The AMA. The AMA. And when President Truman and the administration failed in driving the legislation, we morphed into the compromise, which is employee-sponsored health care, which then required the build-out of an insurance industry to move from community rating to underwriting, and that's the world we live in today. And the only way employee-sponsored insurance could come into being was there was a tax break associated with it. So this picture incorporates an initial president who tried to create a single-party system, and President Johnson, who really decided that it was time the federal government support the health and well-being of retirees in America. And you can't easily read this, but let me read it to you because I just think it's an amazing statement. President Johnson said that day, "No longer will Americans be denied the healing powers of modern medicine. No longer will illness crush and destroy the savings that they've so carefully put away over a lifetime so they might enjoy dignity in their latter years. No longer will young families see their own incomes, their own hopes eaten away simply because they are carrying out a deep moral obligation." What a story. What a program. What a program. But the problem was that in 1965, here on the left-hand side of the slide, 20 million Americans were eligible to participate in Medicaid, and the average cost per beneficiary was $287. Fast forward 50 years, there are 44 million Americans who now participate in Medicaid with the average annual cost of about $8,300 per beneficiary. Some other things that didn't quite square with the financing of Medicare. In 1965, there were 5 working Americans for every 1 beneficiary. By 2027, in a slide I'll show you in a minute, there'll be 2 working Americans for every 1 Medicare beneficiary. And as you know, the funding for Medicare is provided by a payroll tax. So the millennials and younger generations now are taking on this added burden of financing this extraordinary plan. In 1965, one other fact that sort of belies the current condition, the average American was expected to live for 3 additional years. Fast forward to 2016, the average American is expected to live to the age of 78, and so 13 or more years of participation in Medicare. And those factors have created a fundamental financial crisis for the Medicare Trust Fund. That crisis is illustrated on this slide, where one sees in the blue line U.S. government revenue, all sources to the U.S. Treasury, and that's in the blue line. And the red line is U.S. expenditures on 4 programs: Medicare, Medicaid, Social Security, and the federal debt. And you see this interesting moment in 2027 in which, as a result of baby boomers entering Medicare, the total amount of federal government revenue will be consumed in just those 4 programs. Meaning no money for defense, no money for education, no money for whatever your social good is, unless we borrow money or fix the problem of the rising cost of healthcare. And that is why healthcare has taken on such political dimensions. But let's remember that I think fundamentally, if we can deal with the biology and deal with some of the issues of the demography through technology, we have a way to move this forward. Now, fast forward another 50 years, and another landmark piece of legislation, the Patient Protection and Affordable Care Act, a piece of legislation that was designed to actually create a basic human right whereby every American would have access to care. That's, in essence, what the Affordable Care Act attempted to do. Another extraordinary piece of social legislation. But like Medicare 50 years earlier, it was hard to get the financing right. And the struggles with the Affordable Care Act out of the box were 2. One, the funding of the exchanges, the idea being that if young individuals under the individual mandate were forced to pay for insurance, they could create sufficient opportunity in the marketplace that those with chronic conditions could be cared for. Unfortunately, the penalty for not participating, if you were a millennial, was a tax penalty that if you said, okay, I'm going to pay $900 of a tax penalty, or I'm going to go out and try and buy a $5,000 health insurance premium, people made rational choices. So the problem was getting the financing and the actuarial assessment right. And as you remember, the Affordable Care Act, much like the Medicare Act, the financing kind of got pinned on as the plane was running down the runway, right? And so there were struggles, not with the concept and the good, but with the financing. And the biggest issue that came out of the Affordable Care Act was this idea of payment reform, where we were going to change the way that providers were paid for care. The idea being that utilization and lack of transparency around price were driving up costs, and if you could bring those things under control through a series of payment reforms, that would change the dynamic. But payment reform really meant cuts to providers, because to reduce the cost of care, there were 2 options. One, reduce benefits to Medicare beneficiaries. I don't think so, right? Politically untenable. Or to reduce what you pay providers for those services. And so buried in the out years, and now affecting all of us that are the providers, are cuts to Medicare that were basically programmed to fund Medicaid expansion. That plus some of the taxes that were put into the system to do that. So for providers like Inova or George Washington University or the University of Virginia, over the next 2 years, we will experience $150 million of cuts to Medicare payments to pay for Medicaid expansion. Now, it's not that we can't sustain those cuts, but one of the challenges when you attempt to reform delivery care by simply cutting what people get paid is you actually reduce access. So, just to the south of us in North Carolina, 45% of primary care doctors no longer are accepting new Medicare beneficiaries because they will not accept the reduced payments associated with that, which they find unaffordable. So an approach that simply limits or relies too heavily on cutting benefits, this death by 1,000 cuts, has the unintended consequence of worsening the problem of access to care. And we know that some of these early experiments, this is the idea of accountable care organizations, have been extremely difficult to implement and extremely tepid in terms of their ability to drive reform. So here's some of the early data from the Accountable Care Acts, where you can see on the left-hand side that basically only about 400 hospitals out of 4,000 hospitals in America agreed to participate. And of the 400 that did, only 20% got any additional benefit. The other 75% actually paid money back to Medicare. And so that immediately created everyone wanting to get out of the accountable care organizations. And let me tell you about the unique situation in Virginia. Virginia ranks among the lowest quartile in cost per Medicare beneficiary. Charlottesville is the 14th lowest cost for Medicare beneficiary of 304 Medicare MSA areas. 14 lowest. So there's not a lot of more juice to squeeze in an area like Charlotte. So now fast track that to Houston, where the cost per Medicare beneficiary is 2.5 times what it is in Charlottesville. And you could see how Memorial Hermann actually benefited from this, because a lot of low-hanging fruit when your costs are that high. So the application of this kind of payment reform in Virginia has been very troubling, because overall, from a national perspective, the cost per Medicare beneficiary is relatively low. So payment reform is not an effective way to drive this fast enough to meet this 2027 deadline. And this, the idea of the ACOs reminded me of this cartoon, right? The whole idea was, we loved your proposal was second to none, but we chose none. It was like everyone was supposed to participate, but no one was supposed to win. And this has basically been a relatively ineffective payment reform tool to drive the kinds of savings that we must achieve. The second part of this that has really turned into a somewhat tepid outcome is this tyranny of measurement. And I say that because this is just the University of Virginia experience. We report 484 measures to 11 different regulatory agencies. The infrastructure just to collect the data costs $17 million on an annual operating basis. Now, I will be very honest with you. At the University of Virginia, we are currently focused deeply on improving 10 of those 484 measures, because it takes an enormous amount of organizational bandwidth if you're really going to drive a reduction in mortality. This is my favorite. We report mortality data to 8 different agencies. And if you look up what's the chance of dying at UVA on those 8 different websites, you get 4 different answers. How can that be? Death is the one thing that we can all agree on. We can recognize it without a diagnostic test. You're dead. So how can it be that we're characterized with 4 different rates? This has added 0 value to consumers, and leads me to this other great cartoon. This cartoon is someone lying in bed and the doctor is saying, he's one tough cookie. I've never seen someone come back from an autopsy, right? But this is the idea that how can one data set say that there are 500 people that died at UVA and another one say that there are 400 people that died at UVA? We have really underestimated and underachieved on the quality agenda because of this tyranny of measurement, things that don't matter to most human beings. And here's the other side of that story: 4 publicly reported sets of data that talk about every hospital system in the country: Leapfrog, Health Grades, Consumer Reports, and U.S. News and World Report. Right? These are the places where you get ranked. This is what I call the process of teaching to the test. Right? What do you need to do to get an A in Leapfrog? Not what does the patient want and need and how do you provide it on time the first time, no defect, no error, no waste. It's what do you need to do to get an A? And this is a fascinating set of documents. And I just want to show you, so you asked the question, so you would expect that America's best hospitals would all be ranked top performance in those 4 journals, right? That's what you'd expect. Here's an article from Health Affairs, and I'll just quote from one paragraph. It said, no hospital rated as high performer by all 4 national rating systems. Not one hospital in America was rated as high performing by all of those 4 journals. Only 10% of 844 hospitals ranked as good by one of those journals was ranked as good by another. What is the public? This is why most people look to Angie's List to figure out where to get their care, right? The idea that quality defined by this measurement can drive improvement has been undermined by the idea that this is about teaching to the test, not about fundamental clinical delivery system reform. Another example, Medicare penalizes organizations today for performance on these measures. This slide simply reads that among hospitals that participate in Medicare's hospital reduction programs, hospitals that were penalized had more frequent quality accreditations, offered more advanced services, were teaching institutions, had better performance on other process and other measures. Medicare's grading system doesn't include the Cleveland Clinic. So this idea that somehow we were going to move this agenda forward by a series of regulatory defined outcomes has really led to very, very small improvements. And it's this idea, right? I'm sure glad the hole isn't in my end of the boat. The problem, if you say that there are top 10 hospitals in America, is most Americans can't get to them. The idea that only 10 places are great is never going to solve America's healthcare problems. Every hospital has to get better. Every hospital has to look at its performance year over year and say that it's getting better at this idea of meeting patient need, on time, first time, no defect, no error, no waste. But that's not what grading does. So we're at this crossroads right now, and I think the conversation that's occurring in the Senate is really fundamental to this, where we're asking the question, can we really move forward by just cutting stuff? And I would submit to you, cutting reimbursement to payers and passing costs on to patients will have the unintended consequence of actually worsening access, just at the time that the number of baby boomers are about to double. So these are forms of waste in the system that I would argue are the targets of opportunity, and where I would suggest a partnership between care providers and technology can come into play. And this comes from Don Berwick's wedges of waste. You see harm, overtreatment, failures in care delivery, failures in care transitions, excess administrative costs, and fraud and abuse. So let me give you some examples of this. If you look at the costs in the healthcare system, I listed them on the right here. Most of them are in the form of infrastructure, labor and supplies, and clinical variation. The fact that doctors within a hospital perform things differently and doctors between hospitals for things differently. And I'm going to talk about 3 different platforms that I think can address these fundamental drivers of cost and also work on eliminating defect, error, and waste. So infrastructure can be minimized in terms of big buildings by virtual technologies in this evolving world of virtual visits and e-consults. Labor and supplies is all about the application of machine learning and artificial intelligence that allows one to do things better and faster and at scale. And clinical variation can be addressed directly through the development of predictive analytics. An example of what this means, so you can use various forms of technologies in hospitals that are now highly effective in reducing hospital-acquired infections. These are just data from UVA. You know, we've reduced our bloodstream infections and urine infections by 77%, our surgical site infections by 46%, much of it driven by the application of new technologies to standard work of how one places, maintains, and manipulates catheters. So you stabilize the way the work is done, and then you add the technological benefit of, say, a antibiotic impregnated catheter, and voila, you drive down untoward events. Now, people say, hospital-acquired infection sounds bad. Please raise your hand if you'd like to get one, right? No one ever raises their hand. This is the quintessential form of waste. And what does it mean? People often say to me, well, there's not enough money in this to really make a difference. The PHC4 is the Pennsylvania Healthcare Cost Containment Council that was started by Governor Randall, and I sat on and coordinated their quality committee. And in Pennsylvania, all hospitals are by statute mandated to publicly report their infection rates. So on this slide, you can see that in Pennsylvania, well, let me just show you. In Pennsylvania, there were about 2 million people admitted to 166 Pennsylvania hospitals. And of those 2 million people, 23,287 got an infection. What happens if you got an infection? As it turns out, in Pennsylvania hospital, if you got an infection, your mortality was 9.4%. That's compared to 1.8% if you didn't get an infection. You stayed in the hospital 22 days if you got one of these hospital-acquired infections versus 6. Oh, and by the way, you were readmitted 40% of the time as compared to 16% of the time. So you know all this work around readmissions. The best way to prevent readmissions is to prevent an infection. And here's the showstopper, right? If you got an infection, it cost $20,000. If you didn't, it cost $6,600, roughly $13,000 more for something that I didn't see anybody raise their hand to tell me they wanted one. And if you multiply $13,000 by 23,287 infections in Pennsylvania, that comes out to $327 million a year spent on things no one wants. And I can show you on the left-hand side of that side can be substantially reduced and can be accelerated in their reduction through the incorporation of technology. What really matters to patients are none of those 484 measures that I spend $17 million a year collecting. People want to know, how am I going to do when I get my care with you? What's the complication rate when I can go back to work? And I can say that with confidence because we've visited 6 different consumer groups in Albemarle County. The school board, the Chamber of Commerce, all the senior centers. We met with a group of millennials, and I would say everything I'm about to tell you applies to every consumer segment we talk to but millennials. Because in millennials, convenience and cost are what matter. So what people want to know in Charlottesville is, if I have a heart attack and I go to UVA, what's my chance of survival? That's what they want to know. So if you come to UVA and you have a heart attack, your chance of dying is 4.1% compared to a national average of 2,000 other hospitals where the national average is 6.6%. And then a year later, we reduced our mortality to 3.6%. So how'd you do that? And how is it that at one institution, you can have a 50% lower mortality from a heart attack? 2 technological innovations. One is we put telecommunications and EKG transmission machines in every ambulance in Albemarle County so that when they arrive at the scene, they can transmit the EKG to us, we can get the cath lab ready, and the door to opening up the artery time is 46 minutes at UVA, not 90 minutes, the national average. So the ability to take a telecommunication tool in the hands of EMS and know from the scene whether the patient has got a heart attack reduces the time to getting them fixed by almost half, and that reduces mortality. What about complications? So these are complication rates from heart. Let me back up one slide. This is the overall complication rate. So our complication rates are about 50 to 60% lower than the national average. Again, 2,000 other hospitals. And why is that? Well, technology, again, has driven our complication rates low. We have no bleeding, 1,500 heart attacks, 2 years' worth of data, no bleeding following a heart attack. That occurred because we developed the technology of doing the catheterization through your hand, not your leg. Many centers have developed this now. That technology allows bleeding to be totally eliminated. The average patient that bleeds following their heart attacks, 3 extra days in the hospital, about $17,000 more of cost. You don't have bleeding, you save $17,000. And please raise your hand again if you'd like to bleed after you have a heart attack. And I could go on and on. I'll show you one other example. This is the idea around colorectal surgery, the idea of applying this technique called ARIS. Over a 3-year period, 43% reduction in mortality, 2-day reduction in length of stay, 84% reduction in opioid use, 41% reduction in readmissions. And I could go on and on and on. Process improvement driven by technology in the hands of individuals that can create standard work, eliminate things that no one wants. And if we can recoup that money, then you can really begin to think about healthcare reform. Cutting your way out of it won't work. So platforms we're very interested in are predictive analytics involving neonatal sepsis. We're working very closely with colleagues at MITRE Corporation on this idea of being able to tell when premature babies are getting sick. They don't actually say, hi, I'm getting sick. And so we're able to actually stream every 6 hours using physiologic data and technology MITRE has helped us develop to understand how is this baby doing, better, worse, or about the same. It's like the weather channel in the neonatal ICU, except you can't intervene in the weather, but you can in a sick kid. Telehealth, as I mentioned, we'll be doing 60,000 virtual visits. That will save us from building one full medical office building. A cost avoidance to be able to reach people at a distance where they don't have to drive, we come to them. And I think building these platforms is going to be extremely hard. And the whole idea that Senator came of the prevention. Prevention today is too transactional. You come to see me, I say, have you had your colonoscopy? Did you get your mammography? What's your blood pressure? Don't smoke, please walk, don't eat fat. And I measure your cholesterol and that stuff. And I do it once. And the other 364 days you're walking around doing whatever the hell you want to do, right? But with wearables, implantables, trainables, shockables, cloud-based coaching, you can have someone on your cell phone giving you a friendly reminder, please don't eat that piece of cake. But it becomes much less transactional and much more in the line of people's work. And these are just some other things. I see the sign that says stop, so I'm going to stop. But I think we have to reinvent the partnership with industry. And one of the things we're very excited about in our partnership with Inova here in the Center for Personalized Health is the Global Genomics and Bioinformatics Institute that we're going to build. But once upon a time, the idea of a company coming into a university to do work side by side with university scientists was thought to be this quintessential conflict of interest. Today, we have a whole team of AstraZeneca scientists on grounds in Charlottesville doing experiments in atherosclerosis with Charlottesville scientists. Why? Because we have this problem in biomedical research. I go out and I do the experiment in my lab, I publish it, and then no one can reproduce my work, right? Only 1/3 of published results in the field of molecular biology can be reproduced by a biopharmaceutical company. That is an enormous waste. But if the biopharmaceutical company and the scientist do the experiment together, in the same space, in the same room, you avoid all that rework. I mentioned the MITRE-UVA partnership in precision analytics and this idea of hovering. MITRE, through its work with the military, has developed extraordinary ways to monitor battlefield conditions. If you can monitor battlefield conditions in Iraq, you can monitor battlefield conditions at home and actually understand social, behavioral, and environmental determinants. The partnership, as I mentioned, with Inova is astonishing. The idea that we're going to be able to be here working with George Mason to develop this integrated global genomics and bioinformatics institute. We're going to create a single data science institute. Not everybody build their own data science institute, a single data science institute, which allow us to understand these fundamentals of big data. You know this beautiful building, and I'm sure you'll hear more about it in the day. Invert the scientific pyramid. Right now, everything about science is I get down to the smallest part of the human molecule I can find, and then I try and find one target and one disease it works in. It is a needle in a haystack approach. What if you take all the claims data in the world and all the drugs in the world, and you do an analysis about where are there approved drugs who seem to have an impact on a disease we never thought they would work on? So a big part of the big data idea is, can we get better at refining targets by finding a drug that was designed for, treating an infection, but turns out to be highly beneficial in treating, in this particular case, macular degeneration. So a drug used to treat HIV turns out to be an extremely potent drug in minimizing the development of macular degeneration. No one did that experiment. They looked at big data, found the association, and now are doing human trials of that already approved drug, but to see, will it halt dry macular degeneration? Just examples of this. I think the final thing I want to say to this audience, places like Inova, George Washington, Virginia Tech, UVA, are willing to put skin in the game. This is no longer the handout for you to write the check, right? This is the handout to say we need to partner in this. And this is just a list of funded initiatives at the University of Virginia through our Strategic Investment Fund this year on topical areas. Money that the University of Virginia is investing, looking alongside to find partners. And one great example of this is the type 1 diabetes effort. A scientist at UVA discovered the 2 mutations in chromosome 6 that explains 90% of the risk of getting type 1 diabetes. There are 50,000 kids in Virginia with type 1 diabetes. It's an inherited condition. But as it turns out, if you have those risks, you don't always get diabetes. There's some environmental trigger. So what's the plan? We're going to screen every kid in Virginia under the age of 5 free of charge, and then follow them for 10 years by wearables and implantables and monitoring the environment, trying to figure out what's the environmental trigger that causes a child to go from being at risk for type 1 diabetes to developing type 1 diabetes. And our idea would be move that whole program here, because it's a hell of a lot easier to get to Fairfax than it is to get to Charlottesville. But the idea of partnering around those sorts of targeted conditions. So we put $17 million up, and we have a term sheet in front of us now from Janssen Pharmaceutical that they want to match it with $10 million to combine the genetic information we're going to gather in Virginia with the entire country of Finland, which the entire country of Finland's been genotyped. But it's very homogeneous, right? It's not like Fairfax. So the idea of being able to pool these resources and bring in commercial partners to really double down on these diseases is important. Okay, I'm done. This is the last slide. We talk about the triple aim, but the key to driving the triple aim better and faster is the idea of bringing biotechnology together with the delivery system. I believe access to healthcare is a human right. The reason why we don't have access to healthcare for all Americans is healthcare is unaffordable. And the only way to make healthcare affordable is to improve it by eliminating defect, error, and waste, and by using technology to drive productivity and efficiency better and faster. That's a formula for reforming healthcare, not just cutting everything about healthcare. So thank you very much for your time.